Good morning, everyone. I'm going to talk on dialysis in liver failure today. My outline of talk is about classical paradigm or the nephrologist paradigm of initiating and maintaining on renal replacement therapy, and perspectives on the evolution of renal care in acute liver failure, incidence of acute kidney injury in acute liver failure and its effect on survival, need for ammonia clearance in patients with acute liver failure through renal replacement techniques, methods of ammonia clearance, and beyond ammonia clearance, other hepatotoxins that accumulate in liver failure, and anticoagulation strategies that can be used in liver failure. And lastly, society international and national societal recommendations for the management of kidney injury in liver failure. So this is the definition that allows a diagnosis of AKI. Any increase of more than 0.3 in 48 hours or 1.5 times of increase in creatinine over 7 days is diagnosed as acute kidney injury, going by the KDIGO criteria from 2012. The same thing has been adapted by International Club of Ascites for the diagnosis of acute kidney injury in liver disease patients. This, however, is for cirrhosis patients and does not include urine output criteria. This includes increase in creatinine of more than 0.3 over 48 hours or more than 50%, 1.5 times increase in serum creatinine from a baseline that at admission compared to in a period of 7 days. Stage 1 is 1.5 times, stage 2 is 2 to 3 times, and stage 3 is more than 3 times requirement of RRT or a serum creatinine of more than 4. When to initiate RRT, KDIGO says other than life-threatening indications of fluid, electrolyte and acid imbalances, broader clinical context has to be considered, and present clinical context being liver failure, ammonia has a significant say in the initiation of RRT. So this is how applications of RRT were classified in the KDIGO statement. Apart from the classical paradigm of renal replacement, the present guideline also includes what's called renal support, or the initiation of hemodialysis for volume control, electrolyte control, nutrition, drug delivery, and also solute modulation. And in the present context, it's ammonia clearance. So KDIGO further recommends continuous removal of toxins and CRRT for when continuous removal of toxin, hemodynamic stability is fragile, and easy control of fluid balance and no treatment-induced increase of intracranial pressure, and user-friendly machines. These are the situations where CRRT is recommended over intermittent hemodialysis, all of which are applicable for patients of liver failure who are at high risk for increased intracranial pressure and are hemodynamically unstable. So in AKI in ALF in India versus the West, where acetaminophen is the most common cause of ALF, has a lesser prevalence of AKI from 10 to 30%. This is from King's College London, where the incidence of AKI in ALF was 80% and 65% of which were stage 3 AKI, and it significantly affected survival and also the length of hospital stay. Stage 1 no AKI or stage 1 to 2 AKI had shorter length of hospital stay versus stage 3 AKI. Factors that considered risk factors for the development of AKI from this Royal Infirmary Edinburgh study was, other than paracetamol-induced acute liver failure, were KCH, poor prognosis, hypoglycemia, treatment for increased intracranial pressure, that is the use of mannitol, then hypotension, and systemic inflammatory response syndrome. Systemic inflammatory response syndrome, this study was the first one to point out SIRS to be a major cause of AKI in these patients. In acute on chronic liver failure, AKI at admission was noted in 33%, and new onset and progressive AKI was noted in 13%, 26% of whom required RRT, and it significantly affected survival. Admission creatinine of less than 0.6 had survival mortality of 20% versus 35% in 0.6 to 1.5 creatinine group, and 58% in those with creatinine of more than 1.5. So the molecule of the day, ammonia. which significantly elevated in acute liver failure and causes all the pathophysiological manifestations. The intestines are the primary source for ammonia, which physiologically is cleared by the liver and some amount of by the muscle and also the kidney. Kidney also contributes some amount of ammonia through bicarbonate regeneration, all of which accumulates in the brain, causes accumulation of glutamine and astrocyte swelling, leading to cerebral edema and increase in intracranial hypertension. So other situations where ammonia gets accumulated is in errors of metabolism, where urea cycle defects in these enzymes, ornithine transcarbamylase, arginosuccinic acid synthase, arginosuccinic lyase, and arginase can also cause an increase in ammonia concentration in the blood and lead to cerebral manifestations. So in ALF, this is a study from 1999, but they could cannulate the hepatic vein and demonstrate that the gut is the primary source and liver is unable to clear ammonia. In patients with acute liver failure, hepatic venous ammonia concentration is far higher than what is seen in acute and chronic liver disease and control patients. This accumulation of ammonia, which is almost 230 in those patients who developed cerebral herniation versus those who did not develop cerebral herniation. So 140-200 is kind of cutoff where it is considered to be severe enough to cause encephalopathy and put the patient at a risk for cerebral herniation, which can be prevented by decreasing this ammonia level. Here again we see that the systemic arterial ammonia in ALF was 148 and hepatic venous concentration was 203, and a value of 230 or so predicted cerebral herniation during the admission. This is again from Dr. Bhatia, who actually in the study from Ames, a cutoff of 124 arterial ammonia level predicted mortality with a 76% sensitivity. So ammonia has a significant role in the pathophysiology of ALF and intracranial hypertension. So clearance of ammonia was reduction of ammonia by the use of various medical therapies has always been the cornerstone of management of encephalopathy in liver failure. And this is a chart of treatment modalities that have been tried in King's College, where they have seen that over a period from 1973 to 2008, there has been a change both in the spectrum of etiologies as well as the treatment modalities that have been adapted. All of which they say as a bundle predicted improvement in survival to up to 70% by the end of the study period. As far as renal replacement is concerned, until 1990 it was hemodialysis, and later on there was a change to continuous hemofiltration, which they believed allowed administration of 30% saline and better fluid control and control of ammonia. So they say that the thresholds in their center at least progressively fell over time, and during the present day it's not just standard indications for acute kidney injury, but also for relative oliguria, metabolic stabilization, and hyperammonemia that they consider early RRT in these patients. And survival has been progressively improving decade over decade. So this is from the US Acute Liver Failure Study Group. This slide actually shows the efficiency of CRRT in the removal of ammonia. This is day one from the point of admission to the study, and at admission around 61 patients received CRRT with an initial ammonia of 140. By day 3, which reached almost near normal value of 87, which was not the case with either intermittent renal replacement therapy or no replacement. This is though intermittent renal replacement therapy is led, or intermittent hemodialysis as we call it, is effective at removal of ammonia. There's a rebound in ammonia, so there isn't any difference between the no RRT and intermittent RRT groups in terms of ammonia concentrations. So this effective removal of ammonia with CRRT had improved survival in these patients. The 21-day transplant-free survival was better in these patients. So what actually determines the removal of ammonia is blood flow rate. Increasing blood flow rate increases ammonia clearance, whereas a dialysate flow rate of 300 ml per minute kind of plateaus off when used high dialysate flow rates. ammonia clearance progressively increases with blood flow rates. And also with increasing dialyzer surface area, there is an increased ammonia clearance and a better and efficient clearance. In terms of continuous therapy, this was the first study by Slack et al., who included both acute liver failure and acute and chronic liver failure patients. And though the modality per se was a little doubtful in terms of added efficiency, because ammonia is only 17 kilodaltons and need not use filtration techniques, and dialytic techniques would also be as effective or even more effective. However, they showed that with an increase in effluent volume to 90 ml per kg versus a standard of 35 ml per kg, ammonia clearance paralleled the rise in effluent volume or urea clearance. At 35 ml per kg per hour dialyzed effluent volume, the clearance was 39 ml per minute, versus at 90 ml, the clearance was 85. Ultrafiltration doses that were prescribed were 2.2 to 5.9 liters in general. This is another slide which again supports the use of continuous therapy versus intermittent therapy. This is not in a patient with liver failure, but it clearly depicts the pattern of rebound that happens when intermittent hemodialysis is used to manage hyperammonemia. This was a patient with ureterostomy, and because of when he developed a UTI with a urease producing organism, his ammonia had shot up, and they had to use hemodialysis to rapidly reduce his ammonia. It was around 250. At the end of dialysis, it was even near normal at 57, but within a few hours it again rebound. This is because of compartmentalization of ammonia in the cerebral tissue and other body tissues, as well as continued generation of ammonia. So both these things, the effectiveness of removal in continuous therapies and the rebound that happens in intermittent dialysis, and also the survival benefit on retrospective studies, actually argue for a case for continuous therapies to be used in hyperammonemic patients rather than intermittent dialysis. So, putting together the dose requirements and the continuous therapies, this slide actually shows that using higher flow rates at the beginning of our CRRT will rapidly reduce ammonia levels, and then a lower maintenance dose of just 500 ml per hour can prevent rebound hyperammonemia. This graph is used to be used for representation. This is actually a child with citrullinemia, and he had very high ammonia levels of 800 or so, and presented with encephalopathy. And at the initiation, they have used 5000 ml per hour at dialysate flow rates. And once the ammonia came down after a day, and they continued a maintenance of only 500 ml per hour. So continuous therapies, initial intensive therapies, have been shown to be, at least on clearance basis, more effective than intermittent therapies. In patients with inborn errors of metabolism, all these modalities have been used. Continuous, dialytic and filtration techniques have been used for the management of hyperammonemia. In this slide, we can actually see that the most effective, or the median time for 50% reduction in ammonia, was best with intermittent hemodialysis. But the problem with intermittent hemodialysis is the rebound, and so is no longer recommended for the management of hyperammonemia. This is the typical patient type that is seen these days, and typical practice pattern for the use of RRT for hyperammonemia. And this is from Varillo et al. From Australia, and this is a case series of 54 patients, where almost 70% of patients, 80% of patients had grade 3 or 4 encephalopathy, and the predominant cause was acetaminophen related. 40% of patients had acute renal failure, and they were really sick, with mechanical ventilation requirement in 83%, vasopressor requirement in 83%, and despite standard medical therapy, who had persistent hyperammonemia. The lactate was 5.6 at the initiation of CRRT, and they have initiated CRRT very early. Within 4 hours of admission itself, they started CRRT, and that had led to significant reductions in ammonia levels in these patients, and had improved survival. Though there was a bleeding risk of 11%, 60% had transplant-free survival. And the modalities that they have used are again continuous veno-venous hemodiafiltration in almost 80%, and that's the kind of standard therapy that's been used in most centers these days. However, what is interesting to observe is they could manage flows of 200 to 300 ml per minute, and with maintained hemodynamic stability and in fact better hemodynamic stability after the removal of ammonia. Ultrafiltration volumes were kept high for a rapid reduction of ammonia. And given the coagulopathy in these patients, they could not use any anticoagulation in 67% of the patients, and citrate was used only in 2%. So, use of citrate may actually prolong filter life and efficiency of continuous techniques in the removal of ammonia. Though in this study they have went up to ultrafiltration rates of 5000 ml. Continuing the talk on dose of effluent volumes. In this study from Japan, where other techniques of liver support like MARS aren't available or aren't licensed, what they tried is very high flow continuous hemodiafiltration versus 2000 ultrafiltration rates that we use, effluent volumes that we use here. They use 30 liters per hour flows using a separate machine that could generate 30 liters of dialysate per hour. And with this they achieved rapid removal of ammonia and improved survival. 62% it was. Here again we can see that versus plasma exchange or versus slow plasma exchange with continuous hemodiafiltration. High flow continuous hemodiafiltration at effluent volumes of 30 liters per hour had a better survival in their series of patients. And also the ammonia removal was very rapid and consistent. So based on all this data on the use of continuous therapies and use of higher blood flows, higher dialysate flows, an algorithm has been proposed by Dr. Ashita Tolwani published in Blood Purification in 2019, where she suggests that despite standard medical therapy, the ammonia is more than 200. She suggests initiation of renal replacement therapy for hyperammonemia at a very high dose of 5000 ml per hour until ammonia is less than 100, and then to maintain it at 500 ml per hour dialysate flows with an effluent flow rate of 35 ml per kg. There are studies which showed that 25 versus 40 had equivalent clearances of ammonia. And the very low study also showed that it was the duration of CRRT that was more important than flow. Though a little controversial, but if a rapid reduction of ammonia is necessary, then using dialysate flows of 5000 ml per hour would cause better clearance of ammonia and rapid stabilization. Continuing the continuous dialytic techniques in resource poor settings like in Brazil, this study was from Brazil, and they have used peritoneal dialysis in patients of acute and chronic liver failure. And though the survival was very poor, only 15% survived till 90 days, and the most common cause was infections that led to the demise. However, technically, PD was able to maintain adequate solute clearance. They achieved a KTV of 2.7. In maintenance PD, what is used is 1.8 to 2 is considered adequate enough. And they would achieve good clearance as well as good control of blood urea nitrogen, which fell from 101 to 46 by day 6, and creatinine, potassium and ultrafiltration. They could achieve a 3 liter per day ultrafiltration through the use of PD in these patients. However, leakage and bleeding were common in these patients and led to technique failure in almost 20% of these patients. When these techniques are not sufficient for the improvement in encephalopathy, and then other techniques like albumin dialysis can be used. And I have limited myself to albumin dialysis, and bioartificial kidneys are not part of the talk. And here we see the most common techniques that are used as albumin dialysis. The first is the molecular adsorbent recirculating system. Here the molecular absorbent is the albumin. There's an albumin circuit and then there's a blood circuit. Here we have a hemofilter which is high flux, which is albumin impermeable. However, it adsorbs albumin onto its surface so that the albumin bound toxins in the patient's blood could be exchanged for the albumin in the albumin circuit. The albumin circuit picks up the toxins and delivers it to an anion exchange resin and a charcoal resin. and so is efficient at removal of albumin and other hepatotoxins, other toxins that accumulate in liver failure. Prometheus is the system that's used. Here the filter that's used has a pore size of 250 kilodaltons, so most of the plasma is actually filtered out, which goes through two exchange columns, an ion exchanger and again a charcoal column, and which is returned to the blood, and so no extra albumin or added albumin is added to the circuit. Plasma if a fresh frozen plasma is used to maintain the coagulation parameters. Single pass albumin dialysis is expensive in terms of albumin that is used, because albumin, once it is used to dialyze the blood, is discarded. However, in terms of initiation costs, it is cheaper. All of these modalities are carried on for 6 to 8 hours. And in terms of clearance, these are all the substances that are purported to be removed: conjugated or unconjugated bilirubin, protoporphyrin, bile acids, glycoside derivatives, phenols, short and medium chain fatty acids, octanoate, heterocyclic organic compounds, and even TNF alpha, L6 and IL-10 are also removed. However, the data is consistent only in terms of bilirubin and ammonia and amino acid. Amino acid is tryptophan and glutamine removal. These are the supposed indications for acute liver support, artificial liver support, most of which is acute liver failure due to acetaminophen or non-acetaminophen hepatitis A and B, severe alcoholic hepatitis. And there are other indications where it has been tried with doubtful efficacy, HRS type 1 and type 2 too. And the present role seems to be confined to this place where the patient is awaiting a liver transplant, and these artificial liver support techniques are used to manage hepatic encephalopathy or prevent irreversible liver damage when there is a delay in procuring a suitable organ. Post liver transplant, the primary non-function is another indication for use of artificial liver support. Intractable pruritus in cholestatic liver disease also has been in this situation also it has been used, and specific molecules like SLRP1 are removed in artificial liver support techniques. This is a meta-analysis from 2015 which showed that though the removal of bilirubin happens to the extent of around 7 milligram per deciliter, and there is a significant improvement in encephalopathy grade, and both with Prometheus and Mars versus standard medical therapy. This included both patients with acute liver failure and acute on chronic liver failure. On all the studies included were randomized controlled trials. Both for the effect on encephalopathy and the decrease in bilirubin, these two techniques have been effective. However, they did not improve the mortality, improve survival. This is the latest data which again from the ALF study group. This here is to represent the kind of changes that happen both clinically as well as biochemically in these patients. The technique that's described here was Mars, and it showed significant improvement of hemodynamics and decreased inotropic requirements, better lactate clearance in patient, better hemodynamic stability and in these patients. This is supposed to be because of removal of nitric oxide from the blood. However, there is a significant drop in the platelet count in these patients. Ammonia, there is a significant reduction of ammonia seen here. Even in acetaminophen toxicity also, the removal of nitric oxide led to better hemodynamic stability. 21-day transplant-free survival was better in these patients. And this is the latest data from US acute liver failure study group. Clearance parameters have been studied in terms of single pass albumin dialysis versus Mars, and they have been almost similar in terms of clearance of decreased changes in bilirubin, gamma glutamyl transpeptidase, changes in creatinine and urea of these patients. Other than ALF, it has been used, Mars has been used in, Mars and Prometheus have been used in type 1 HRS, cholestatic pruritus and post-apoplectomy liver failure. And one thing that's consistently shown improvement was the rating score for pruritus in cholestatic in pediatric patients. So that's about the indications for acute liver, artificial liver support and the effectiveness in terms of biochemical parameters, but not with survival. Citrate anticoagulation. In liver failure, there's a coagulopathy, and to maintain better filter life, one can use citrate solutions, which is added pre-pump, so that the calcium is chelated and the blood doesn't clot within the filter, and which is neutralized with a calcium infusion back to the patient, so that the arterial calcium in the patient is maintained well. This citrate, however, has to be metabolized is metabolized both mainly in the liver, and so in patients with severe liver failure, citrate accumulation is a potential risk. However, it improves filter lifespan, and here we can see that clotting-free filter survival, almost all filters function until 72 hours in this patient, in this study, which is liver citrate anticoagulation trial, which is an observational study, in fact. And whether in patients with versus normal liver function, and even in patients with severe liver failure, arterial pH, arterial bicarbonate, base excess were all well corrected, even in patients with severe liver failure with a bilirubin of more than 7 in this study. However, regional citrate anticoagulation has its own attendant problems, which include bleeding, hypocalcemia, metabolic alkalosis because of citrate overload, and acidosis when there is citrate toxicity, hypernatremia when a hyper-concentrated citrate is used, and hypomagnesemia if a magnesium-free replacement fluid is used. So this is the famous Gajinov study, where he described rules for the identification of citrate accumulation. A fall in pH from 7.3 to 7.20, an increase in ratio of total calcium to ionized calcium to greater than 2.5, an increase in anion gap, were all noted as predictors of citrate accumulation, even without measuring citrate levels within the blood. So in these patients, there were cardiac arrhythmias and worsening hypotension, which led to lactate increase from 7.7 to 15, and it led to severe increase in mortality in those patients who accumulated citrate, and those proportion of patients who accumulated citrate was 15% in this study. So, how to predict citrate accumulation? These are area, and this is the ROC curve for prothrombin time, and prothrombin timer of more than 33 seconds is also with a 0.92% accuracy in terms of area under the curve in terms of predicting citrate toxicity, and this is lactate of more than 3.4 also is predictive of citrate accumulation, and when correlated, the total calcium to ionized calcium ratio of 2.5 also predicted citrate concentration in the blood. When citrate accumulation toxicity does happen, citrate flows should be reduced and dialysate flows should be increased to prevent further the occurrence of severe hypocalcemia and cardiac arrhythmias and mortality. So, despite all this, large number of trials have used regional citrate anticoagulation both in cirrhosis and liver failure, and most of them found it to be useful in terms of circuit lifetime and acid-base status. Citrate accumulation was ranged from in a few studies it wasn't seen at all. Most of the studies had it between 4 and 10%. So, summarizing, and also the recommendations that were proposed by EASL were: the early initiation of extracorporeal therapy should be considered for persistent hyperammonemia in patients with AKI, or even without AKI, with just hyperammonia in patients with ALF, and control of hyponatremia and other metabolic abnormalities, fluid balance, and potentially temperature control also. Mild hypothermia is used often, and the temperature of 34 to 36 degrees centigrade is considered acceptable, though active hypothermia to 32-33 degrees centigrade also has been used. Anticoagulation of CRRT circuits remains a matter of debate. Citrate can be used safely, and it prevented any clotting episode within the first 24 hours and allowed the use of the same filter for up to 72 hours. Continuous CRRT should always be undertaken in critically ill patients as opposed to intermittent hemodialysis. Intermittent hemodialysis is no longer recommended. Indian National Association for Study of Liver Disease also has similar recommendations. They say that AKI is less common in Indian patients because acetaminophen is not the predominant cause of liver failure in our patients, and the occurrence of AKI has been associated with poorer outcomes, prolonged stay, reduced spontaneous survival, and reduced survival at 1 year. They also recommend RRT for ALF with AKI should be initiated as per standard indications, as well as early initiation for hyperammonemia. The continuous RRT should be preferred over intermittent hemodialysis, same as what the European Society said. However, the use of anticoagulation, they use of half dose of ultra unfractionated heparin when the coagulation parameters are acceptable, and citrate also can be used. Patients with ALF who fail to respond to standard liver intensive care have have higher mortality, and so they advise use of, if available, liver assist devices can be used as bridge, but they have overall failed to improve transplant-free survival without a transplant. They can be used as a bridge, however. So, thank you.